let's suppose now we move it on again. Let's say, you talk about somebody who's perhaps, they've maybe tried this, or they're even beyond, you deem them to be beyond the scope of those kind of biologics injections, and they've got to the point where they probably are having to contemplate some sort of prosthesis, by which we mean a knee replacement. And that a knee replacement, I'm right in thinking, can come in several formats. We can have a total knee replacement where we're replacing both sides of the knee as plus or minus the kneecap, or there can be a unicompartmental, where they're just doing the disease side if the arthritis is all confined to just the inside half or the outside half. In terms of, let's say, somebody who's just got pain or disease on one half of the knee, would you say that it's always best to start with a unicompartmental knee?
I think it goes back to you're absolutely right. So that there's I guess a lot of variety, and we're blessed with that. I think the key is, at the end of the day, the patient history and examination, more than anything. So if the symptoms are, predominantly on one side of the knee, if their examination suggests, let's say, let's take medial compartment OA. If the patient, comes in, if you ask him, put your finger, where your pain is, and generally for me, it's a crude test, but if they point all over the knee, then it's telling you that their symptoms are coming from all over the knee. If they point just to the medial aspects of the knee, and their examination is such that they're in, a varus alignment, which is, correct, largely correctable, and their investigations, their weight-bearing X-rays, which is probably all you need. We often will have an MRI scan as well, and it shows isolated medial compartment OA. And when we say isolated, you still would accept some lateral changes, some patellofemoral changes in terms of radiographs or MRI changes, but the symptoms need to be predominantly, medial side. Then, absolutely, I think that patient, should be offered a unicompartmental knee. But you need to go again through the consent process. What are the benefits? Well, the real benefit from a partial knee, as you rightly point out, you're just replacing the diseased aspect of the knee. You're keeping the key drivers in the knee, the ACL ligament in the knee, which, is considered the driver knee, that's being preserved. So kinematically, the knee functions more normally. It feels more normal. One of the big criticisms, this kind of figure, which is bantered around, 20% of patients having total knees are dissatisfied. One of the reasons is that, okay, well, their pain is improved, but the knee just doesn't feel quite normal, doesn't feel their own. Whereas partials, you can get very close to getting what they call a forgotten knee. We very much achieve it with the hip joint and hip replacements, but with the knee, it's less, the outcome scores are less good. The SF-36 and quality of life indices are less good. So what we're seeing with partial knees is actually it feels much more like a normal knee. The flip side is that the data, and we have very good data, as we collect all of this on the National Joint Registry, which is all in the public kind of domain, which tells us that partial knee replacements are generally, revised around 8 years, whereas total knee replacements, you look at the data and, by and large, most knee replacements, good quality knee replacements are above that 90%, centile over 10 years. So again, when I'm consenting, you typically say to a total knee replacement, 10 to 15 years of use, even longer. Partial, you say it's less than that. But, the trade-off is that, you can do much more activity with it without, much more sports, younger patients, isolated medial compartment OA. I think it's a better outcome, better operation, and they accept that they may have to have a procedure some way down the line.